Recording. Perfect. Okay, so today we are going to be covering chapter 31 and 33. 31 is male genitalia and reproductive function. Okay, disorder of the penis and the male urethra could be congenital. That means that you are born with a defect, acquired infection, or neoplasia. Micropenis is when the penis is small, less than 1.5 centimeter. Etiology and pathogenesis: defect in testosterone production most of the time, and the deficiency that result in poor growth of target organ. Diagnosis: evaluate endocrine anomaly, measure serum testosterone. Of course, we have to measure testosterone because it's the one that facilitates the expression of secondary sexual characteristic, and one of the secondary sexual characteristic in male is the penis. Okay. Also LH, FSH, those are other hormones that we also check. Also, you have to check if the patient have those genetic conditions like Prader-Willis or Kallmann syndrome. Those are genetic, or Klinefelter syndrome. Those are genetic conditions that predispose the patient to have a micropenis. Most of the time the treatment is testosterone. Urethral valve anomalies. Majority of anomalies occur posteriorly and is distal prostatic urethra. Common cause of urinary obstructions. Valves are mucosal fold that resemble thin membrane. Valve cause obstruction when child attempt to void, and that's why you retain the urine and the patients have urine ectasis and develop frequent infection. Okay. Etiology: abnormal insertion and persistence of the distal Wolffian duct. Wolffian duct is one of the structure, embryological structure from where we develop the internal organs. Okay. Persistent urogenital membrane. Clinical manifestation: intrauterine renal failure causing oligohydramnios. Oligohydramnios is one of the first signs and symptoms, one of the most common signs and symptoms that give you an idea that the patient has problem with the kidney. Okay. Then we have pulmonary hypoplasia. Pulmonary hypoplasia because it's also problem with the patient doesn't have the recirculation of the of the amniotic fluid, and then they don't develop the lungs. Okay, stillborn or extreme distress at the time of birth. Urethral valve anomaly, clinical manifestation: inability to void, normally void within 24 hours of birth. Abdominal mass such as palpable bladder or hydronephrotic kidneys. Varying degree of azotemia or renal failure. Azotemia means that the patient has elevation of BUN and creatinine. Okay. Urinary ascites and floating bowel on X-ray. The treatment: you have to give plenty of fluid to the patient, always to maintain the renal functions. If the patient has an infection, you treat the infection with antibiotic, and you have to put a catheter. That's most of the time the first treatment. Okay, you put a catheter to drain all the urine. Ablation of the valve and cutaneous vesicostomy in infants. Ureterorectal and vesiculorectal fistula, those are communication that sometimes we have inside. Okay. ureterorectal and vesicoretral. Ureterorectal means that you have communication between the urethra and the rectum, okay? Vesicouretral, that means that you have communications between the bladder and the urethra, okay? This is rare or almost always associated with imperforated anus and caused by failure of the urethra septum to develop. Septum to develop. Clinical manifestations, pass of feces and gas. Basically, those are one of the main signs and symptoms, okay? When you see a patient that when they urinate pass like bubbles, have like bubbles in the urine, and the urine is like with all of the feces, then you start thinking about fistula, okay? Diagnostic, you have to do a cystoscopy and construct enhanced radiography, those are image, and the treatment surgery, okay? Then we have hypospadia. Hypospadia is that we have the penis, and in the penis, at the tip of the penis, we have, this is the penis, right here, this is the gland, and always right here in the middle, we have the meatus, okay? That's the opening for the urine to come out, okay? So, hypo is under, hyper is over, okay? That means that this is the patient, then you have the penis right here, okay? This is the gland, this is the meatus. If you have this opening here or in any part from here all the way to here, that's hypospadia. If you have the opening from here all the way here, that's hyperspadia, okay? Because we have hypospadia and hyperspadia, okay? Etiology is incomplete function of the urethral fold, meatus located anywhere between the perineum and glands. 85% involve the glands or corona, and the treatment always is surgery, okay? And we have question number 1. A patient have hypospadia. Which finding will the nurse observe upon assessment? And the answer is D, exactly. Urinary meatus on the vertebral undersurface of the penis, vertebra, okay? The penis, let me go back again that you have an idea. This is the penis, okay? This is the ventral part, and this is the dorsal part, okay? Epispadia, you see that we have hypospadia and epispadia. Epispadia is the opening in the dorsal, okay? Etiology and treatment correlate with extrophy of the bladder. This is a special for epispadia, okay? In hypospadia, we don't have this. Okay, in epispadia, we have extrophy of the bladder. That means that the bladder is outside of the abdomen, okay? Because of failure of the abdomen wall to form, may extend proximally to involve urinary sphincter, and the treatment is surgery. Priapism is a painful, persistent erection because of engorgement with blood, okay? And that's the main definition, okay? Painful erection for more than 4 hours, okay? Always has to be painful. Etiology and treatment, idiopathic causes, could be due to sickle cell, anticoagulant therapy, diabetes, leukemia, antidepressant, intracavernous injections, and treat the underlying cause, and aspiration of the blood, injection of alpha adrenergic agents, or surgery, okay? Priapism could be due to medication, okay? Like there is a medication that is called Viagra. Viagra can produce priapism, okay? And the other name is sildenafil. Phimosis. Phimosis is the foreskin, okay? Foreskin, that is the prepusio. Prepusio is the skin that covers the penis. If you don't have circumcision, when you do the circumcision, you remove that skin. But you are not circumcised, then you have the skin, and the skins, sometimes when you put the skin back, you can put it, to the front. Okay, you can retract the skin, and then that produce priapism. That's the famous priapism. It's common, for example, for all of you that are gonna be a nurse. When you put a Foley catheter in male, you have to retract the priapism. Okay, yes, the foreskin, the skin. When you finish putting the Foley, you have to put it back, okay, because that can produce phimosis. Okay. Oh, I mean, I was confused. Okay, phimosis is the cause of phimosis is because of inflammation, infection, poor hygiene. That's the most common cause of phimosis. Okay, this one is the one that you can produce because of iatrogeny. In the case that you put the Foley and you don't retract the foreskin, and then that produce paraphimosis. Okay, paraphimosis. Peyronie's disease is a formation of a palpable fibro plaque on the surface of the corona cavernosa. Okay, this is in the penis. It's a formation like fibrosis in the penis, and that produce pain, and also the penis start like bending like this. Okay, and then right here you have like fibrosis, and that when you have an erection, that produce a lot of pain. Okay. The treatment is there is no satisfactory treatment. You could use colchicine. Uh, you could use some medication, but if that medication failed, you have to do surgery. Okay. Urethral stricture. Urethral strictures is fibrosis, narrowing of the urethral stricture could happen in any part of your body. Okay, and a stricture is always like fibrotic tissue that develop right there in that area, and that produce obstruction. Okay. Clinical manifestation: decreased urine stream, urethral discharge, bladder infection. Why? Because you retain the urine, you produce urine ecstasis, and that you develop infection. Okay. Diagnostic: you do cystoscopy, retrograde ureterogram. Those are images. Okay. And the treatment: dilation, incision, or surgery to remove all the tissue. Okay. Erectile dysfunction, or impotence, uh, or inability to achieve or maintain an erection. Okay. Erectile dysfunction is that you can have an erection to satisfy the female. Okay, that's basic. Or the erection is not hard enough to penetrate the vagina. Okay, that's erectile dysfunction. Okay, could be primary or could be secondary. Okay, primary is inability to attain an erection throughout life. That means that you never have an erection in your life. Okay, secondary is that you have erection and now you can make an erection. Okay. In the secondary cause is the most common one and could be due to peripheral vascular disease, especially in patients with diabetes, coronary artery disease, okay, arterial insufficiency, atherosclerosis, stenosis, okay, and endocrine problem like diabetes, pituitary dysfunction, okay. Also due to medication like antihypertensive, especially beta blocker, antihistamines, uh, phenothiazide, and some antidepressants, okay, especially SSRI, SNRIs, all those medications can produce erectile dysfunction, especially decreased libido. Okay, trauma also pain a fracture, pelvic fracture, iatrogenic cause like arterial vascular surgery, radical pelvic cancer surgery, and psychological causes. The treatment, you have to evaluate the patient if the patient has some psychogenic or organic cause. Okay, if the patient have organic cause or psychiatric problem. Surgical interventions could be one of the treatment. Intracavernous injection, that is a prostaglandin injection in the penis to achieve the erections, and selected inhibitor of cyclo-guanine monophosphate. Okay, the mechanism of action of those medications, Viagra, Levitra, and Cialis, is phosphodiester inhibitor. Okay? And also you could use a vacuum device. Neoplasm of the penis etiology is extremely rare. The neoplasm of the penis phimosis can result from chronic inflammation. Most common cause, extremely low incidence in circumcised men, 95% squamous cell carcinoma. Okay, metastasis occur by lymphatic dissemination. Mm, That's neoplasia of the penis extremely rare. Maybe you never see a case in your life. Clinical manifestation, ulcerative and fungated lesions. You have to be very careful because ulcerative lesions are more common in uh, STD, okay, sexual transmitted, exactly, STDs, okay. But the way that you differentiate an ulcerative lesion from STD to neoplasia is the time, okay. For example, syphilis produces ulcers in the penis, but that ulcer is gonna last like 2 months, I think like 2 weeks. After 2 weeks, the ulcer is gonna be gone, okay. So if you have a patient that the ulcer that have patient that have an ulcer in the penis for 2, 3, 4 months, then you have to do a biopsy because most probably is a cancer. Okay. Treatment depends on stages like every other cancer. Topical chemotherapy and radiation, partial penectomy. Unfortunately, sometimes we have to remove the penis. Prognosis depends on stage of carcinoma. Okay, let's keep going. Also, we have problem in the scrotum and in the testes that could be congenital, acquired infection of neoplasia. Uh, the first is cryptorchidism. Cryptorchidism is that the testes don't descend to the scrotum, okay? A scrotum is basically the back of the male. That back is called a scrotum. So that's why when you have a newborn baby, I always like to give advice to all of you because one day you're gonna be in the hospital. And you are in the, for example, in the labor and delivery that you have to receive the newborn baby, you have to do a physical exam. When you do a physical exam, that you see if the patient has the testis in the scrotum, you have to grab one testis and you have to hold it and find the other one. Because if you grab one testis and you say, "Look, there is one right here," and you release and try to grab another one, maybe it's the same one, okay? Because they move, okay? That's why you have to grab one, hold it, and try to find the other one. If you have both, then you say that the patient is okay. If not, then the patient have cryptorchidism, okay? What is the problem with cryptorchidism? The testis is gonna be inside, okay, in the pelvic cavity, and put the patient at risk for testicular cancer, okay, infertility, and a lot of complications, okay. So the treatment increase incidence of malignant if untreated, orchiopexy, and human chorionic gonadotrophy. Okay, the treatment is to put down the testes. Okay, you have to follow one structure that is in the testes that is called the gubernaculum. Okay, you have to find the gubernaculum in the scrotum, and you go through the gubernaculum all the way to the pelvic cavity, and you find the testes. That's how you find the testes. And then you anchor the testes to the the testes to the scrotum. Okay, you have to do that surgery before 2 years old. Why? Because after 2 years old, the risk for testicular cancer increase. Okay, so you do it before 2 years old to decrease a little bit. Still, the patient is gonna be a higher risk to develop scrotal cancer, but they decrease a little bit if you descend, the testis before 2 years old. Now we have hypogonadism. The incidence is 4 to 5 million, cause primary testicular failure, and we have the androgen deficiency in the aging male and andropause that cause erectile dysfunction, loss of muscular tone, osteoporosis, and lipid metabolism change. Okay, diagnosis, you have to check the level of testosterone and replace with testosterone. Hydrocele, that is a fluid collection surrounding the testis of a spermatic core and contained in the tunica and processus vaginalis. Okay, that's hydrocele. Okay, that's basically accumulation of fluid, especially right there in the processus vaginalis. Tunica vaginalis, that's another name. Okay. Develop secondarily to scrotal injury, radiation therapy, infection of epididymis, or testicular neoplasia. Okay, the treatment, surgical drainage. If painful, that means if you have sign and symptom. You don't have sign and symptom, you don't do anything. Spermatoceles etiology is a painless cyst mass containing sperm. Okay, can be large and difficult to distinguish from hydrocele. Okay. Cause is unknown, and treatment, there is no treatment unless cause discomfort. That means that you start feeling sign and symptom. Okay, if you feel sign and symptom, you drainage surgically. Testicular torsion is an emergency. Okay, that's an emergency. Okay, that's twisting of the spermatic cord with compromise of the vascular supply. That's why if you compromise the vascular supply, you produce ischemia. If you produce ischemia, then you produce infarction of the testis. That means that the testis is dead. Okay, occur primarily in prepubertal male. So those patients that have testicular torsion, the presentation of those patients is a sudden onset of testicular pain. Okay, it's gonna be sudden, sometimes after trauma. Okay, clinical manifestation, severe sudden pain in one testis. Okay, swelling of the scrotum, nausea and vomiting. And one of the tests that you do to to see to confirm the problem uh, in the physical evaluation, in the physical exam, is when you have testicular torsion, you lost the cremasteric reflex. Okay, you could Google it, cremasteric reflex. What is cremasteric reflex? And then you're gonna see. Is when you touch the inside of the thigh of the male, the scrotum shrink. Okay, that's cremasteric reflex. Okay, in those patients, the cremasteric reflex is lost. And they have pain all the time, okay, because that's another differential. Okay, patient with testicular torsions, they have pain all the time. If you lift a little bit the testicle, the patient is gonna have pain also. Okay, and that's a differential with epididymis. Okay, patient with epididymis, when you lift a little bit the testis, the pain go away, okay? Diagnosis, you have to do ultrasound and you have to untwist the testis before 6 hours, okay? You have 6 hours to untwist the testis to avoid the necrosis, okay? Treatment, emergency treatment, surgery to untwist the testis. First, you try to do it with the hands. Then, if you don't do it with the hand, then you go with the surgery, okay? If the torsion is accomplished within 12 hours, prognosis is usually good. Okay? You have to memorize this. The real number is 6 hours, but because your book say 12, then you have to go with your book. Epididymis, okay? Epididymis is inflammation of the testis epididymis, okay? From trauma, reflux of sterile urine up to the vas deferens or secondary to a bacterial infection. Clinical manifestation is enlarged, rectus, tender scrotum, pain with radiation into the inguinal area, fever, urethral discharge. We have a lot of signs and symptoms. Okay, treatment, if the patient has systemic symptoms like fever, then you put the patient in antibiotics. Okay, fournier gangrene is a complication. Okay, it's a severe but rare condition involving gangrenous necrosis of the scrotum. Manifest by pain, scrotal swelling, fever, chill, and sepsis. Okay, diagnostic is with history and physical examination. You have to do ultrasound and CT scan or MRI. Okay, treatment, incision and drainage. Okay, debridement, you have to remove all the necrotic tissue and you put the patient in antibiotic. We have a question number 2. Which of the following is a medical emergency? Exactly, testicular torsion is a real emergency, okay? Now we have neoplastic disorder, okay? Neoplastic disorder, you have some statistics right here. The peak is in the late adolescence or to early adulthood. Most common solid tumor in men, age 20 to 35. Early detection with testicular cells examination. Etiology associated with cryptorchidis. Remember, you have cryptorchidis, then you are at risk to develop cancer in your life. Histologically, two groups: non-germinal neoplasm of Leydig cell and germinal neoplasm. Okay, 4-stage progression like any other cancer. Treatment: the treatment and prognosis vary depending on histology subtype. Seminomas in early stage, easy treatment with radiation therapy. Non-seminoma germ cell tumor in early stage, treated with surgery. Choriocarcinoma are often not found until late stage and are aggressive. The treatment: most germ cell tumors can be effectively managed even after lymph node metastasis. Typically have surgery to remove the testicle and spermatic cord. One part that is special for testicular cancer is that you never do a biopsy in testicular cancer, okay? Never. Biopsy is contraindicated in testicular cancer. BPH, benign prostatic hyperplasia, is a condition that is common in males, especially after 60 years old, and is inflammation of the prostate gland, okay? Clinical manifestations, most of the time the clinical manifestation is urinary retention, obstruction of fluid, and nocturia. That's one of the main characteristics. Nocturia means that the patient has to wake up at night to go to the bathroom, okay? Another characteristic is that when the patient go to the bathroom, they have to push. They have to do like some efforts to pee because the urine doesn't come out. Okay. Diagnostic test is DRE, digital rectal exam. Rectal exam, that's the real name. Digital rectal exams, bladder scanning, CT, and ultrasounds, and urodynamic study. The most common one is rectal exam and PSA. But in medicine, we don't do PSA routinely, and we don't do PSA because they have some instruction. The patient has to avoid sex for like 3 days. It's a little bit complicated. The treatment is alpha blocker. That's the first treatment. Alpha blocker, if the patient is too old and have problem with orthostatic hypotension, then you put it in another medication. Surgery is extremely controversial for benign prostatic hyperplasia because also for prostatic cancer, surgery is extremely controversial because the patient you when you remove the prostate, the incidence of erectile dysfunction is extremely high. Okay, and we have question number 3: a patient present with possible benign prostatic hyperplasia, which technique will be used to help confirm the diagnosis? Exactly. The answer is rectal examination, digital rectal examination. Prostatitis, inflammation of the prostate, could be acute bacteria, chronic bacteria, non-bacteria is the most common one. Prostatodynia, that's pain in the prostate, okay? E. coli is the most common organism. Remember that the E. coli is a normal flora in the urinary tract system. A route of infection is reflux urine, rectal invasion, and hematogenous and urinary catheter. Okay, clinical manifestation: the patient with prostatitis is gonna have fever, chills, low back pain, uh, frequency, urgency, dysuria. Rectal examination is tender, swelling prostate. Okay, in chronic prostatitis, voiding symptoms with pain in perineum, back, suprapubic area. Okay, diagnosis: you have to use to do urinalysis. Okay, to confirm that the patient have bacterial infection. Okay, the treatment, of course, is antibiotic. Okay, it's always antibiotic. One of the most common antibiotics is this trimethoprim sulfametazole. Okay, and also we use other medication. Okay. Alpha adrenergic receptor alpha blocker is the common medication used for benign prostatic hyperplasia. Okay, prostate cancer is the most prevalent cancer in men. Is the second leading cause cancer death in men, and rare in men younger than 50 years old. Okay. Etiology: causes unknown, contributing factors are genetic, hormonal, dietary, and vital. Okay, prostate cancer is a little bit controversial because there is no screening for prostate cancer, okay, unless the patient asks for examination, okay, for screening. But normally there is no routine screening for prostate cancer. Why? Because prostate cancer is extremely common, okay? There is some statistics, some study that show that every 80% of all the men over 80 years old is gonna have prostate cancer, okay? And most of the time you die with prostate cancer, no from prostate cancer, okay? That's why it's a little bit controversial. Okay, sometimes you see a patient that the patient died like 75, 80 years old because of heart attack, whatever, anything, any reason. And you do the autopsy, you could see that the patient maybe have a prostate cancer and they never feel anything. Okay, that's why it's a little bit controversial. The treatment and the screening also. Okay, that's why never offer screening for prostate cancer to the patient unless the patient asks you, a doctor, listen, I have a problem, I don't know if we can, then you have to do a physical exam and family history. Okay, if the patient doesn't have any family history, any risk, then most probably you don't do anything. Okay, because it's extremely rare that the patient is going to develop cancer early in life that is gonna kill the patient. Okay. Diagnosis is a rectal examination, biopsy, of course, and PSA. PSA, this is the PSA, okay? You do the PSAs and transurethral ultrasonography also, okay? The treatment is, you see, watchful and waiting. That's basically the main treatment, unfortunately, because most probably the patient died from another reason, not from prostate cancer, okay? Unless the patient have a really aggressive tumor, and then you do the surgery. Okay, and always remember that one of the main complications of that surgery is erectile dysfunction. Okay, any question from this chapter? No. Okay, perfect. I hope you learn a little bit, but let's go to the next chapter. Okay, we done with male. Now we go with female. Remember that male, we are really simple species, but female are extremely complicated species. Okay, so now this is chapter is a little bit longer. Okay, because female are extremely linked to hormones. Okay, so let's go start with the menstrual disorder. We have amenorrhea. Amenorrhea is that you don't have menstruation. Okay, no menses. Okay, and that have a time frame. Okay, it has to be more than 6 months. Okay, cause we have hormonal disturbance, stress, neoplasm, treatment aimed at the underlying cause, hormonal supplementation, and surgery. Okay, I'm gonna make a question right here. Who know what is the most common cause of amenorrhea? Of course, in female. Who know what is the most common cause of amenorrhea? Exactly. Pregnancy. Exactly. That's the most common cause. Thank you, Emily. Perfect. Exactly. Okay, now let's keep going. Now we have metrorrhagia. Metrorrhagia is a bleeding between menstrual period. Okay, causes slight bleeding from endometrium during ovulation. So metrorrhagia is a lot of bleeding. Okay, hypomenorrhea is that the menstrual flow is decreased. Okay, and one of the causes is endocrine or systemic disorder interfering with hormones. So if you are talking about hormones, endocrine is the same, okay? Then we have oligomenorrhea. Oligomenorrhea is infrequent menstruation, okay? That means it's decrease of the menstrual cycle, okay? Polymenorrhea is too much menstruation, okay? Menorrhagia is increase in amount or duration of bleeding, okay? Treatment is surgery, oral contraceptive. That's one of the most common treatment. Most of the time, if the female have problem with menstruation, you put in OCP to see if the patient improve. Abnormal uterine bleeding pattern, okay? Dysfunctional uterine bleeding, abnormal endometrial bleeding not associated with tumor, inflammation, pregnancy, trauma, or hormonal effect. Okay, somewhere around time of menarche and menopause. Okay, adolescent, immature in functional of the pituitary and ovarian. That's the most common cause in adolescents for abnormal menstrual bleeding. Okay, the most common cause is immature of the pituitary ovarian axis. Okay, then you put the patient OCP, and most of the time the patient improves. Okay, perimenopause, progressive function, and failure of the ovary to produce estrogens. And we have question number 1. Which term should the nurse use to describe infrequent menstruations? Exactly, oligomenorrhea, okay? That means infrequent menstruation. Dysmenorrhea means pain with menstruation, okay? One of the most common causes of dysmenorrhea is oh my god, I forget the name of that disease. Endometriosis. Okay, that's one of the most common causes of dysmenorrhea. Okay, we have primary, not related to any pathology condition, develop 1 to 2 years after menarche, result from increased prostaglandin that promote uterine contraction and ischemia of the endometrial capillaries. Okay, then you have to be very careful. If you have problem with prostaglandin, you have to give NSAID to the patient. Okay, char, suprapubic cramping severe enough to limit activity, nausea, vomiting, diarrhea, and headache. Those are some of the signs and symptoms. We have secondary dysmenorrhea associated with pelvic disorders such as endometriosis. Okay, pelvic adhesion. Pelvic adhesion is common in patient after surgery. Okay, the patient has surgery and later in life they develop adhesions. Okay, dull quality and may increase with age. Treatment: prostaglandin inhibitor. I don't know why they put prostaglandin inhibitor right here, but prostaglandin inhibitor is NSAIDs. Okay, steroid hormone is extremely risky. Of course, you have to be very careful with steroid because the patient have cancer for any reasons, you worse the condition. Okay, OCP, laparoscopy is most of the time the treatment for endometriosis, treat underlying problem for secondary. Uterine prolapse. Okay, uterine prolapse is when the uterines they uh, is basically outside of the vagina. Okay, is protruding outside of the vagina. Result from relaxation of the pelvic structure and cervix. Okay, cardinal ligament. Those are one of the ligaments that maintain the cervix in place. Okay, can occur of any age, cause congenital defect, pregnancy, especially multiparate woman, okay, and childbirth. Uterine prolapse, first degree, second degree, and third degree. That's I think it's not really important for you at this time, but you have to know what is the symphysis of the pubis, and then according to the relation, you know, if first degree, second degree, third degree, and there is another one that is fourth degree. Okay, that is completely prolapse. Okay, clinical manifestation depend on severity of prolapse, sensation of fullness, vaginal discomfort, okay, difficulty urination, and the treatment is hysterectomy or pessary. Pessary is a device that you put in the vagina to keep the uterus in place. Okay, retrodisplacement of the uterus. Retrodisplacement of the uterus, body of the uterus displaced from usual location underlying bladder to posterior of the pelvis. Okay, body of the uterus flexes or rotating to the posterior pelvis. Can be detected in 20-30% of the woman, may be present throughout woman life or develop after childbirth. Okay, causes could be congenital, pregnancy, and we have 5 position, okay? Anteroverte means position, anteroflex, retroflex, and retroverter. Clinical manifestation in many women is completely asymptomatic, or maybe that produce pain, dysmenorrhea, dyspareunia. Okay, dysmenorrhea is pain with menstruation. Who know what means dyspareunia? Dyspareunia. What means dyspareunia? Nobody know? Okay, dyspareunia means pain with sex. Okay, infertility, treatment, not treatment if not symptoms, cesarean or surgical correction. Okay. Cystocele. Cystocele is a protrusion of portion of the urinary bladder into the weakened part of the anterior vagina. Okay, cystocele is like a cyst formation in the urinary bladder. Okay, cause injury, aging, obesity, and heavy lifting. Clinical manifestation depend on the severity, and one of the main clinical manifestations is this that produce incontinence. Okay. Uh, Treatment: surgery, repair of the vagina, and restore bladder to normal position. May use prosthetic mesh. Rectocele, okay, we have cystocele is a cyst of the urinary bladder. Rectocele is a cyst of the rectum, okay. It's protrusion of the anterior rectal wall. It's a cyst from the rectum, okay, and protrude to the vagina. Causes injury during childbirth or surgery, weakness with aging, multiparty, obesity, and postmenopausal status. Clinical manifestation depend on the severity. The patient could develop constipation, painful bowel evacuation, painful intercourse. I don't know why they put dyspareunia in the other side and now they put painful with intercourse. That's the same. Painful with intercourse is dyspareunia. Treatment: surgical repair of vagina to restore rectum to proper position. PID, pelvic inflammatory disease, is any acute, subacute, recurrent or chronic infection of the oviduct, ovaries, and adjacent product organs. Okay, oviduct is the fallopian tube. Okay. We have cervicitis is in the cervix, endometritis in the uterus, salpingitis in the fallopian tube, that is the oviduct, oophorytis is in the ovaries, and parametritis with connective tissue underlying this structure is involved. Okay. Common organisms is Neisseria gonorrhea and Chlamydia trachomatis. Okay. Causes: alteration of cervical mucus, pelvic surgery, insertion of intrauterine device, abortion procedure, infectious during and after pregnancy. Okay, let me see. We have clinical manifestation in those patients is pain with when you touch the cervix, the patient develop a lot of pain. Okay, that's one of the main clinical manifestation. Okay. Fever, elevated WBC, and purulent vaginal discharge. Okay, complication: fertility, ectopic pregnancy, and chronic pelvic pain. Treatment in pelvic inflammatory disease: early and aggressive antibiotic therapy. That's the main treatment. Okay, right here we have rupture of pelvic abscess. Okay, if the patient develop abscess, you have to be very careful. Okay, when you put the patient in treatment in aggressive antibiotic, the patient has to improve 3 days after. If the patient don't improve 3 days after, then you start thinking about pelvic abscess. Then you have to do an image to see if there is an abscess, and if there is an abscess, you have to do a surgery because the abscess rupture that can produce bleeding, okay, and the patient get into the shock. Vulvovaginitis is inflammation of the vulva and vagina. Common organism, this is the most common one. Candida albicans. Candida albicans is a fungal infection. Also could be bacteria or viral. Other predisposing factor: chemical irritation, allergy reaction, feminine hygiene products, toilet paper, trauma, antibiotic therapy, postmenopause, and also patients with diabetes. Patients with diabetes are at risk to candida infection. Okay. Antibiotic, why? Because if you abuse of the antibiotic, you kill the flora, and if you kill the flora, then you develop the infection. Candidiasis clinical manifestation is a thick, white vaginal discharge. That's the main characteristic. Okay, the vagina, the cervix is gonna be red, edematous mucous membrane. Okay, intense itching. Other infectious agent manifestation: malodorous, purulent discharge, red, swollen labia, pain or urinary and urination and intercourse, and itching. Treatment: local or systemic antibiotic. That it depends. Okay, there is just two type of medication that we use for vulvovaginitis. Okay, because there is three main pathogens that produce vulvovaginitis. Let me see if we have another one. No. Okay, there is Candida albicans. Um, the other one is Trichomonas vaginalis, and the other one is Gardnerella vaginalis. Okay, those are the three ones that produce vulvovaginitis. If you have Candida albicans, you have to give antifungal. You have the other two, Gardnerella vaginalis and Trichomonas, you give the patient metronidazole. Okay. Bartholinitis is inflammation of the Bartholin gland. Those are glands in the vagina. Okay, you have, this is the vagina right here, then right here, and right here. At 4 and at 7, you have the Bartholin gland. Okay, so you have a patient that have a bulking mass right here, painful, then the patient have Bartholin cyst. Okay. The treatment is appropriate antibiotic therapy, and the main treatment is incision and drainage. You do incision and drainage and put the patient in antibiotic. Uterine leiomyomas. Okay, uterine leiomyomas, also called myomas or fibroids. Okay, etiology is the most common uterine growth. 50% of all premenopausal women, 20% over 35. Black 3 times more than white, and make appear and growth during reproductive year. Growth enhanced by high estrogen and growth hormone levels. Clinical manifestation: abnormal vaginal bleeding and discharge, if large mass, abdominal pain and pressure, back pain, constipation, urinary frequency, and urgency. Treatment depends on the sign, symptom, and location. Okay, if too large, you have to do surgery. Okay, or sometimes hysterectomy. Ovarian cyst. Ovarian cyst is a sac in the ovaries. Okay, those ovarian, the most common one is the follicular, the corpus luteum, and the tunica luteum. Okay, corpus luteum is maturing ovarian follicle failed to release ovum. Follicles continue to enlarge and produce estrogen. El corpus luteum is failing to degenerate normally. Okay, and tunica luteum is commonly bilateral. Clinical manifestation normally produce no symptom when rupture cause intraperitoneal hemorrhage and abdominal pain. Okay, that's why it's an emergency. Okay, treatment, oral contraceptives, immediate surgical intervention if you suspect a rupture. Okay. And we have question number 2. A nurse is preparing to teach the staff about ovarian cysts. Which information should the nurse include? Ovarian cysts are exactly filled with fluid or semi-solid material. Okay, that's one of the description. Okay. Endometriosis is increase the risk in multi-party. Is a benign disease but tend to infiltrate and spread to adjacent tissue. Okay, is the presence. This is the pathophysiology. Okay, right here is the presence of endometrial tissue outside of the lining of the uterine cavity. Okay, that's the pathophysiology. That tissue could go any part. Okay, like right here in the ovary, peritoneum, oviduct, outer layers, the uterine, bladder, intestine, and also sometimes reach to the lungs. Etiology theory is transportation, metaplasia, and induction. Okay, transportation, endometrial tissue flow backward through oviducts. Okay, that's one of the theory. Metaplasia, inflammation of hormonal chains trigger conversion of one tissue to a normal form. An induction is a combination of transportation and metaplasia, both combined together. Endometriosis once implants ectopic tissue, periodical rupture, and bleed in response to reproductive hormone. That's why they have pain during menstruation, a lot of pain during menstruation. Okay, may rupture, spilling, irritative discharge into the peritoneum cause fibrosis. Repeat irritation cause the formation of dense tissue adhesions. Clinical manifestation, dysmenorrhea. Okay, those are the main characteristics. Okay, dysmenorrhea, dyspareunia, pain with defecation is called dyschezia, and those are the main characteristics. Okay, dysmenorrhea, dyspareunia, and dyschezia. Okay, and problem with infertility. Those are the main characteristics. Okay. Treatments vary according to the extent of disease. Goal is to relieve the pain. That's why you put the patient in NSAIDs. Okay. Induction of menopause-like stage with hormonal aging, surgery, excessive of affect structure, and possible hysterectomy. If the patient does not improve with conventional treatment like medication, then you have to do the surgery, and the surgery is hysterectomy. Now we have cervical cancer of the cervix. Okay, it's cervical cancer. Okay, for cervical cancer we have a screening test. The screening test is the Pap smear. Okay, Pap smear test. Okay. One of the main causes of cervical cancer is this. This is the main cause of cervical cancer, okay? Human papilloma virus, okay? And what are the type of human papilloma virus that produce cancer? I think it's 18, 16, 18, 30, 31, 33. Those are the type of human papilloma virus that produce cancer, okay? And you get the HPV through sex. That's why you see that the most common cause are all related with sex. Okay, intercourse at young age, multiple sexual partners, multiple pregnancies, herpes virus type 2, and other sexual transmitted infection. Screening screening after 3 negative year pap test. I don't understand what they mean right here, but the screening for cervical cancer, 30 year every 2 years. Okay, the screening for cervical cancer start at 21 Q3. So start at 21 every 3 years. Okay, that pap smear. After 30 years, you could combine pap smear with human papilloma virus DNA, and you do it every 5 years until 65. Okay, until 65 years old. Okay, that's the screening for that neoplasia. Okay, clinical manifestation, pre-invasive, asymptomatic. That's why we do a screening, because most of the time there is no sign and symptom. Okay, early invasive, abdominal vaginal bleeding, persistent vaginal discharge, pain and bleeding after intercourse. Okay, progression usually beyond early stage when symptoms appear, may spread to the vaginal wall, pelvic, bladder, rectum, and pelvic lymph node. The treatment is cryotherapy, incision, laser surgery. It's a surgery. You have to remove the cervix. Okay, there is like two types of surgery, because we have the endocervix and the exocervix. Okay, if you have damage the endocervix, you have to do a con. If you don't damage the endocervix, then you do the cryotherapy. Okay. Invasive carcinoma, we have hysterectomy, uh, chemotherapy, radiation therapy. Okay, and you see 5 year survival rate. In stage 1 it's 93, stage 4 is just 15%. Prevention, we have the vaccines, and the vaccine can be administered to girls young 9 years. The recommendation is from 13 to 26 years. Not only for girl, also for male. You give to both. Okay, you give the vaccine for both. Cancer of the cervix preventions, vaccine against HPV of the cervical. You have the vaccines. We have different types, 6, 11, 16, 18. The only one that produce cancer is those right here. The 6 and 11, they produce the genital warts. Okay. Endometrial cancer involves endometrial lining of the uterus. Risk is infertility, late menopause, obesity, diabetes, hypertension, and opposite estrogen therapy. Listen, endometrial cancer is related with estrogens. So the more that you are exposed to estrogen, the more risk you have to develop endometrial cancer. That's why you see late menopause, because when you have menstruation, you have estrogen. Okay, when you have menopause, you don't have estrogen. So early menarche and late menopause, those are risks for endometrial cancer. Okay. Clinical manifestation: bleeding between menstrual period and postmenopausal bleeding. That's extremely important. Okay. Postmenopausal bleeding. Any woman postmenopausal that have a bleeding, you have to do a biopsy. Okay. Diagnosis: the problem is that in this one we don't have a screening test. Okay. Histology, tissue examination, that's the biopsy. Okay. The treatment: radiation therapy, total hysterectomy. Okay. Now we have ovarian cancer. Ovarian cancer, leading cause of death from genital cancer, peak incidence to 60 to 80, high mortality rate. The problem with ovarian is that also we don't have a screening test. Okay, clinical manifestations not until late in disease when occur include all these. Okay, increase in abdominal girth, weight loss, abdominal pain, dysuria, constipation, and sometimes the patient develop ascites. Okay, ascites, and also develop aumentum cake. Aumentum cake is metastasis to the omentum. Omentum is like fat that we have in the abdominal cavity. When this produce metastasis to the omentum, it's called omentum cake. Treatment remove of the uterus, ovaries, and oviduct. Okay, radiation therapy, chemotherapy, prophylactic oophorectomy or salpingo oophorectomy. Oophorectomy is remove of the ovary. Salpingo oophorectomy is remove the fallopian tube with the ovaries. Vaginal cancer, early to mid-50, young woman whose mother took DES. Okay, I don't. The pronunciation of this is complicated. You remember DES is the same one. Okay, the ethylbestrol is called DES. Okay, so that means that if your mom was exposed to DES, then you could develop, not your mom, you could develop cancer later in life. Okay, possible metastasis. Nowadays we don't use that medication anymore. Okay, that was a medication used in the, I think, the 50 or 60. Possible metastasis to bladder, rectum, vulva, pulmonary pain, and other surrounding tissue. Okay, clinical manifestation: vaginal spotting and discharge, pain, growing mass, change in urinary pattern. Treatment: early stage, treat malignant area while preserving normal part of vagina. Radiation therapy. Okay, preservation of functional vagina is possible only in early stage. Okay, if you catch the disease later, you have to remove the vagina. Okay, cancer of the vulva. Vulva is basically the outside of the genital female. Okay, it's extremely rare. Mortality rate is 1.3 in 100,000. Occur at any age, with a peak in the 60s. Predisposing factors: STDs, of course, chronic puberty or vulva with swelling and dryness. Those are clinical manifestations. Okay, obesity, hypertension, diabetes, never been pregnant, local relapse common with either conservative or radical procedures. Clinical manifestation: leukoplakia. Chain leukoplakia is um, a skin lesions that predispose the patient to uh, vulvar cancer. Okay, treatment: partial incision to remove the lesions, advanced disease, total vulva excision. Okay, you have to remove the vulva. Now we have pregnancy disorder. Pregnancies induce hypertension. Okay, this is called pregnancy-induced hypertension, toxemia, and pre-eclampsia and eclampsia. Okay, leading cause of pregnant-related death, characterized by rapid rise in arterial blood pressure associated with the loss of large amount of protein in the urine, proteinuria. Okay. Pregnancies induce hypertension, risk factor: teenager, late in 30 in the 40, multi-fetus, pre-existing condition, cause: poor nutrition, genetic, immunologic factor, clinical manifestation, weight gain, edema. Let me see, because I don't see anything. Okay, let me go back. Okay, listen. Hypertension in pregnancy is divided in three type of pregnancy. This type of hyper okay, hold on. This type of hypertension is only for women who don't already have hypertension before, right? Yes, okay, let me explain because this PowerPoint is not the best, okay? Okay, hypertension in women, we have different type of hypertension, okay? We have essential hypertension, is woman that when they become pregnant, they used to have hypertension, okay? Then you keep with the treatment of hypertension. That's one diagnosis. Then we have another diagnosis that is women that when they become pregnancy, they develop hypertension. Okay, before 20 weeks of pregnancy without proteinuria. Okay, that's one type of hypertension pregnancy. Now, preeclampsia and eclampsia. Preeclampsia is women that develop hypertension after 20 weeks of pregnancy with proteinuria. That's preeclampsia. Now, eclampsia is hypertension after 20 weeks of pregnancy with proteinuria, and the woman develop seizure, have a seizure. That's eclampsia. Okay, that's why when you see a patient that is hypertensive, pregnant, you do urine analysis with proteinuria. That's preeclampsia. Then you have to give the patient magnesium sulfate to protect the patient to develop eclampsia. Okay, that's the main treatment, magnesium sulfate. Now we have hyperemesis gravidum. Hyperemesis gravidum is excessive vomiting during pregnancy. Okay, vomiting during pregnancy is completely normal. Okay, the only difference is that hyperemesis gravidum is patient that keep vomiting after the first trimester. That means after 13 weeks of pregnancy, the patient keep vomiting. Okay, then that's hyperemesis gravidum. Also, those patients develop hypertension, proteinuria, and ketonuria also. Okay, it's not right here, but those are one of the main characteristics. Okay, treatment: IV therapy to correct metabolic nutrition deficit, antiemetic. You have to be very careful. There is only one antiemetic that you could use with. You have to be very careful with pregnant women, okay? Because medication have category for pregnant, okay? Now we have placenta previa. Placenta previa means that let me see, okay? This is the woman right here, okay? This is the inside. Okay, let's see that this right here is the uterus, okay, and this is the cervix, okay. So placenta previa means that the placenta is anywhere right here, okay. If the placenta is in any part down right here, close to the cervix, that's placenta previa, okay. Cervical os, that's the cervix, okay, and that's placenta previa, okay. More common with multiple pregnancy, cause is unknown, may interrupt fetal oxygen supply, cause maternal hemorrhage, treatment, C-section, okay. Uh, Patient with placenta previa, the presentation of those patients is painless bleeding. The woman is gonna have bleeding and no pain, okay, that's placenta previa. Painless bleeding in pregnant woman, placenta previa. Okay. Treatment is avoid sex. You have to avoid sex, and you need some rest. You have to be very careful with rest. Okay, woman, pregnant woman never go to the bed. Okay, when you are pregnant, you have to avoid to be in bed. Okay, because pregnancy put you at risk to DVT, and you on top of that, add that the patient is, in bed, you increase even more the risk for DVT, okay? Abruption placentae. Abruption placentae is a separation of the placenta, okay, from the uterus. That could be one of the causes trauma, okay, trauma, hypertension, severe hypertension can produce abruption placenta. Now, the difference in the presentation is that those patients is gonna have painful bleeding. So, painless bleeding, placenta previa. Painful bleeding, abruption placentae. Okay, and could be this trauma, a short umbilical cord. One of the most common causes is also drug abuse, especially cocaine. Okay, spontaneous abortion. Spontaneous abortion is when you expulsion of the product of conception from the uterus before the period of fetal viability. Okay, that means before 20 weeks of pregnancy. Okay, also called miscarriage. Okay, causes, this is the most common cause in the first trimester. That means in the first 13 weeks, the most common cause is chromosomal abnormality. Spontaneous abortions, clinical manifestation, vaginal bleeding, abdominal cramp, may insatisfied at cervix dilation. Treatment if incomplete abortion. We have a lot of type of abortion. Okay, we have a spontaneous abortion, we have complete, incomplete, different type of. Okay, so chromosomal abnormality in the mom or in child. No, in child, not in the mom. Uh, Chromosomal abnormality in the product. Okay, let's keep going. Mammary.ecstasy. Mammary.ecstasy is a chronic inflammatory process in and around the terminal subareolar duct, also called preductal mastitis. More prevalence in premenopause women, collecting duct beneath the nipple and areola become dilated, thinned, and filled with secretion. Mammary.ecstasy pathogenesis duct become distended with cellular debris, inflammations with of granulation tissue created around the small cavity filled with thick yellow-brown material, growth into a palpable mass, fibrous develop into the tissue around the mass. Clinical manifestation: palpable mass of cold, dimple, distortion of the breast or areola, nipple retractions, persist nipple discharge, diagnosis biopsy to rule out malignancy. Treatment: surgical resection or dilation subareolar duct. Breast abscess majority are non-lactational breast abscesses. Okay. Etiology: congenital inverted nipple predisposed for abscesses, syndrome of mammary duct ecstasy, multiple organisms associated with chronic infection, diabetes, and steroid therapy. Clinical manifestation: area of tenderness, redness, and induration under the periareolar skin. Treatment: incision and drainage of the abscess. Okay, and antibiotic. Fact: necrosis is a dead portion of the tissue after trauma. Okay, that's a special after trauma. Clinical manifestation is a painless, ill-defined, firm, poorly mobile mass, skin thickening and retraction. Observation: you do mammography and the treatment incisional biopsy. Reaction to foreign material, that's common nowadays because females get breast implants, okay, with silicone. Okay, recommend to use saline, but that's extremely controversial. Okay, Chest trauma may cause leakage of silicone into the tissue, and that produce inflammation and a lot of reaction. Fibrocystic breast disease, not a distinct disease entity, presence of palpable breast mass that fluctuate with menstrual cycle. That's why when you have any mass in the breast of the female, you have to ask about the menstrual cycle, okay? Etiology common in 30 to 50 years old, microscopy and microscopic cysts with fibrosis. Okay, let me see. Fibrosis breast disease, clinical manifestation, the patient is going to have tenderness or pain in one or both breasts immediately before onset of menstrual cycle. That's why you have to ask if there is any variation during menstrual cycle. Okay? Thin, regular shape, mobile on palpation, located in the upper outer quadrant of the breast, size fluctuate throughout the menstrual cycle. Diagnosis, ultrasound, and needle aspiration. Okay, treatment, danazol, oral contraceptive, and so on. A specific benign neoplasia, we have the fibroadenomas, adenomas, and papillomas. Occur at any time, do not invade the surrounding tissue or metastasize to other sites. Appear as fairly mobile encapsulated mass, that's a special encapsulated mass that are sharply delineated from the surrounding breast tissue. Biopsy and histological examination may be needed to rule out cancer. Always. Cancer of breast, okay, is the most common cancer in female, okay, and the second leading cause of death. The first leading cause of death, cancer in female and male, is lung cancer, okay. In male, 100 times less common, but way more aggressive, okay. More common in white, recommended yearly clinical breast examination and mammography after 40 years old. Okay, this is not a real recommendation, okay? No, that's completely wrong. Okay, that's wrong. The recommendation is after 50 years old. That's the real recommendation. And it's every 1 or 2 years, especially 2 years, every 2 years after 50 years old until 75. That's the real recommendation, okay? Cancer of the breast, risk factor, hormonal factor, early onset of menses and late menopause. Of course, the more you are exposed to estrogens, the more risk you have for breast cancer, okay? Risk factor, reproductive factor, give birth before 18 years old, decrease, and give birth after 35, increase. Low parity, increase. Okay, family history, mother or sister. Okay, when you ask for family history, is first degree relative. First degree relative is mom and siblings. Okay, brother and sister. That's it. Those are first degree. Uncle, aunts, or other relative. That's second degree. Okay. Also, we have the BRCA1 and BRCA2. That's the risk for both breast and ovarian cancer. Risk factor age begin to increase by 20 to 30 years, continue to increase with age. Radiation exposure, history of cancer, pathogenesis arise in epithelium of the glandular duct of breast. Lesions have infiltrate edge that begin to invade normal tissue. Malignant cells begin to disseminate into the lymph system of axilla. That's why always you have to do sentinel axilla. You have to get a biopsy of one lymph node of the axilla. Metastasis to other body side, liver, lung, and bone. Pathogenesis, 5-year survival rate 95% with no lymph involved. Rate drop 25, you have distant metastasis and more positive lymph node, less favorable the prognosis. Okay. Clinical manifestation is pain, less hard, poorly mobile lump, dumpling of the skin, nipple retraction, okay, change in breast contour, bloody discharge from nipple. You have to be very careful because this is an extremely related with intraductal papilloma. Okay. Treatment depend on stage of the tumor expressed. You could do lumpectomy, mastectomy, modified radical mastectomy, and radical mastectomy. Okay, those are the surgery that you could do for the patient. Okay, treatment, surgery, all these are surgery. Okay, lumpectomy, mastectomy, all those are surgery. And chemotherapy. Also, you could use radiation therapy and supported measurement, education, and follow-up. Also, another uh, diagnosis, hold on, let me, diagnosis many discovered with self-examination. Forget about self-examination, okay? That's not a recommendation anymore. Don't do self-examination, okay? Don't touch your breast, female. If there is female, I see that, let me see, we have female right here. Yes, for both of you that are female, don't touch your breast, okay? That's not a recommendation, not even the doctor, okay? Don't let your doctor touch your breast, okay? That's not a recommendation. Recommendation, the screening. What is the screening for breast? Mammography after 50 years old. Okay, sonography, digital mammography, biopsy, those are other tests. And we have question number 3. Which information is correct regarding female disorders? Exactly. Breast cancer, malignant tumor are painless, hard, and fixed in place. That means that they doesn't move. Okay. Any question from this chapter?